Good afternoon, everyone. My name is Sue Hogue, and I'd like to welcome you to the Australian College of Nursing webinar, Dementia, a Patient-Centred Approach, sponsored by Arjo. In the spirit of reconciliation, the Australian College of Nursing acknowledges the traditional owners of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I would like to introduce our speaker, Dr. Stephanie Daly, who is a specialist general practitioner in dementia. Stephanie is a fellow of the Royal College of General Practitioners and has completed postgraduate training in dementia studies at the University of Bradford in the United Kingdom. Since moving to Australia, Stephanie has become an advocate for patients living with dementia and has facilitated the practice she works at, becoming one of the first dementia-friendly general practice surgeries in Australia. Please send questions through the platform for Dr. Daly, and there'll be several audience participation polls, which we encourage you to participate in. Thank you for joining us for what is set to be a great afternoon of learning. And now I'd like to hand over to Dr. Stephanie Daly.
Good afternoon, everyone, and thank you for joining us. So today I'm going to talk to you about dementia, and I'm going to use a patient perspective to highlight the issues surrounding the disease. I just wanted to tell you a little bit about myself, and recently I had to redo my CV, and I was looking back at all the experience I'd had in dementia, and I realised it really began when I was 14 and I used to work in a residential aged care facility. And my job on a Saturday morning was to turn up early, make breakfast for the residents, and then go around their rooms and ensure that they were getting dressed and eating their breakfast. And I got paid the equivalent of about $20 for doing that. And then throughout my career, I've had a wide variety of experience, both working under some psychogeriatricians and doing home visits to the more severe end of the spectrum, as well as managing a GP-led memory assessment service back in the UK. I've also worked in a dementia unit as the main GP, managing patients and their problems. So overall, I've had a variety of experience, which has led me with my interest today. So what I hope to aim to do today is to better empower you to support and assess people living with dementia and be able to identify the key symptoms of dementia and have some tools to really approach some of the issues that might occur in people living with dementia without the need for medication. So, as it's after lunch and everyone's probably a little bit sleepy, I thought I'd do a quiz to get us started. There's no pressure with these answers, it's just a talking point really. But what we're going to do is use the theory behind the Price is Right game, which is a game from back in the 80s where contestants had to rank a series of prizes in the order of their value. And what we're going to do is to rank some diseases, and I'm going to pose one question per slide, and I want you to choose one answer for each slide. So to start with, we're looking at all of these conditions. Now the conditions don't change throughout the slides, so it will be the same list of conditions over the next 4 slides. And I want you to think about which one of these conditions might be the easiest to diagnose. Now I appreciate this might not be all of your roles, but it's just an idea about how we make decisions about whether people have a diagnosis. So for example, if we can launch the first poll while I'm just talking through this list, you might want to think about whether there's a simple test for the disease. So some conditions, you do a test and you find out whether someone has that disease or not. Other conditions, you might be able to do a screening test, for example, which tells you that they have that condition. Or it might be a chest x-ray, for example, or the symptoms might be quite obvious. So, as I said, there's no right or wrong answer, and it's really just to get you a bit engaged in the topic. But if you can all try to finish off your answers. Hopefully you've managed to see the poll. Okay, so if we show the results, we can see that most people feel that things like influenza and diabetes are quite easy to diagnose. And I agree with that because, as I said before, it comes down to having a simple test which helps you to choose whether or not somebody has that disease. So now we're going to look at what might be the most difficult to diagnose. As I said, it's the same list of conditions, and I want you to think about what makes it difficult to diagnose something. So if we can launch this poll again. And again, it's only one answer, and there's no pressure to answer really, it's just to get us talking about the subject. So things that are difficult to diagnose are conditions where perhaps the symptoms are quite insidious. They may have some overlap with other conditions. It might be that there's some stigma around the disease, and so patients might hide their symptoms, or even their carers might hide their symptoms. Or there might not be a clear route in which to get that diagnosis, or the clinicians themselves might not be aware of the diagnosis, or there might not be an accurate test that you can do. So, and as you've all realised, that obviously one of the most difficult to diagnose is dementia. And we'll talk a little bit about why that is when I talk about the clinical symptoms that are associated with it. So now we're going to have a look at what might be the easiest to manage. And I want you just to have a think about the answer to this question. How might something be easy to manage? Well, to my mind, something that gets better on its own is fairly easy to manage because you haven't really had to do anything. You just let the person get better. So that might be influenza, for example. Other conditions like pneumonia, antibiotics might be appropriate, and we know which antibiotics are used for which pneumonias. For other conditions, it might be that there's a clear evidence base of what to do. So for ischemic heart disease, for example, we now know all the medications, or most of the medications that are helpful in preventing a cardiac event. And there's clear evidence behind this. For bowel cancer, for example, it might be that it's just an operation. Cut it out and that's it sorted. Obviously, it's not always that simple. But there are conditions that are easier to manage than others. So let's have a look at how everybody has been voting. And as we said, influenza tends to come up tops with that one, as well as diabetes. And finally, the last poll, I want you to think about what might be difficult to manage and why. So again, it might be that there isn't an effective treatment. It might be that something is eventually a terminal disease. It might be that the disease has lots of different symptoms that come at different times. It might be that those symptoms are very difficult to control or to manage. And all of these things tend to make diseases more difficult to manage. It might even be that the care that's available or the pathways to that care are disjointed and fragmented. And so patients find it difficult to navigate. As you can see from the results, most people have chosen dementia being one of the hardest to manage. So there we have a condition which is difficult to diagnose and it's difficult to manage. And that's why we're talking about it today, because it is one of those diseases that really does pose significant challenges for us as clinicians and health professionals. And this list is not just any random list of diseases, it's actually a list of all the common causes of mortality in Australia. And if we re-rank this list out of alphabetical order into the leading causes of death, we can see that on the next slide, dementia is actually the leading cause of death for women in Australia. At number 2, you've got ischemic heart disease. And if you were to reorganise this list for all deaths, all-cause mortality, so all deaths both in men and women, ischemic heart disease is just at the top. Although I have seen some data coming out from the beginning of this year that suggests that dementia is now overtaking ischemic heart disease in all-cause mortality. So it's hard to diagnose, it's hard to manage, but it's also something that is causing a lot of people to die. And so it's really important that we take heed of this and try to learn more about the condition. So what is dementia? How do we define it? And there's lots of misconceptions about dementia as well. One of the commonest is that it's part of normal aging and that it's purely about memory loss. But it's much more than that. Dementia is actually the term given to a number of diseases, and so it's an overarching term. And there are about 100 diseases that actually cause dementia. The most common ones you'll be familiar with, such as Alzheimer's disease and vascular dementia, but there are lots and lots of other types of diseases that actually cause dementia. For example, Huntington's disease, HIV, there's Lewy body dementia, and there's also Parkinson's disease dementia, to name but a few. But it's something that we might come into contact with in more than just the standard Alzheimer's disease that people are familiar with. It's also a disease that's progressive. It's a neurodegenerative disease that affects the whole brain, and it's a global problem. So you get lots of different symptoms. And in the end, it is terminal. And it's important that we recognise this, because in terms of palliative care, we really need to be thinking about how to manage people towards the end of their disease. So, types of dementia. Alzheimer's disease and vascular dementia are obviously the commonest. And as I mentioned, Lewy body dementia and frontotemporal dementia. And there's just a question that's popped up in the chat, so I'll just answer that now. And it says, isn't dementia a symptom, not a disease? Well, I'd say that dementia is the name of the overarching term for a collection of diseases. It's not the symptom. We'll go through the symptoms of dementia and the clinical manifestations of it in the next few slides, but it wouldn't be classified as a symptom. It's more a name under which you then hold a collection of diseases. So it describes the overall pathophysiology, but it's not really a symptom. So how big is this problem? As you can see here, it financially has a massive implication, and also in terms of numbers. In Australia today, there are 459,000 people living with dementia, but that number is set to rise. And this is from the World Alzheimer's Report. If you just have a look at this slide, thinking about what are some of the reasons why dementia is a challenge for all of us. It's something that most people are worried about, yet lots of patients feel ignored by health professionals, and lots of healthcare providers still think it's a normal process of ageing. And so we really need to challenge these misconceptions that there are about Alzheimer's disease and dementia. Lots of people hide their disease because they realise there's some stigma associated with it. And I really feel that the more you talk about this, the less stigmatising it becomes for people, and the more people will address it. So in our next slide, we're going to start to think about some of the clinical features of dementia. And so I'd like to launch another poll. And I just want you to choose 3 out of this list that you think might be symptoms that are associated with dementia. I'm going to give you a minute or so to answer those. Again, this is just so that we have a think about some of the things. It's not a okay. Okay, so yes, most of these are some of the symptoms that or clinical features that you would associate with dementia. So part of the work I do is with an organisation called Dementia Training Australia, and they have distilled the DSM-5 criteria for diagnosis of dementia into a more simplified form, and so I thought I'd talk about that with you today. They break it down into these 5 key areas so that you can think about some of the features that are associated with dementia. So first of all, cognitive decline. I think that's the one that most people are aware of. So cognitive decline is memory loss. It's often progressive, and it's the sort of things where people will be maybe having repetitive conversation, not being able to follow a conversation when they're in a conversation, or having to go back and read in a book where they were when they've just put their book down and they're unable to recall what was going on in the storyline. They might be getting confused with their medications. They might be not turning up for appointments. They might be forgetting birthdays and anniversaries. And so those are the elements that you might notice with cognitive decline. And it has to be progressive. So you want to find out what was the patient like or the person like 2 or 3 years before, and has there been a deterioration in their symptoms. So, and then we move on to functional decline. So this is when people are having problems with their activities of daily living. So it's things like struggling to go to the bank, or not being able to work out their direct debits, or if they're using internet banking, not being able to remember quite how to do it. It's also things like cooking. So where somebody was able to cook a full meal without a recipe, they're now no longer able to do it. And I had recently had an example of this when a patient of mine was describing somebody that they'd been round for dinner at their house, and they said, did they want beans on toast? And they made the toast, buttered the toast, and then poured just the can of beans directly onto the toast without heating it up. So they missed a critical step in what they would normally have done when making beans on toast. Functional decline is a really key thing that you need in order to make the diagnosis. And it can be things like not being able to get yourself dressed. It could be not being able to do your shopping. And it's really, like I said, about activities of daily living. The psychiatric symptoms that most people are familiar with are the hallucinations. Now, those can start at the beginning of the illness, or towards the end of the illness, or through the middle, and they can come in and out. But equally, depression and anxiety can be features of dementia, and people can present with dementia and anxiety at the beginning of the illness, or towards as part of the illness during the illness disease progression. And it's important that when people do have dementia or anxiety, that we treat that before making a diagnosis of dementia. Behaviour change is something that I think most people are familiar with, and that's when people start to perhaps wonder, perhaps shout out, or get agitated or aggressive. And these tend to be symptoms that people experience later on in the disease. And finally, physical decline. So that's loss of mobility, loss of the desire to eat and drink, and incontinence. And as I said, these also tend to occur later on in the disease process and are associated with more of the terminal phase of the disease. And on this slide, you can see the timeline across the bottom. I said most, although not every person is the same, but most disease takes about 10 years from onset to death. And there are different stages. we try to avoid the terminology of mild, moderate and severe and talk in terms of stage 1, 2 and 3, although naming the stages is useful for patients and carers so that you can help talk about advanced care planning, and just so that they know when things might change. But it's not like somebody's in stage 1 one day and stage 2 the next. And there isn't really any division between these stages. It's more of a fluid thing. But just so that you have an idea of where some of the symptoms might occur. Put this slide here. One of the books that I used in my Bradford University studies had a lot of quotes from patients. And I think it's really important that we remember that there is a patient, there is a person underneath all diseases, but particularly with dementia, because there can be a lack of ability to communicate. You have to still remember that there's a person who feels things beneath that. So always remember that when you're dealing with people living with dementia. So have a think, what sort of things might people find a challenge when they're moving into aged care? What might the challenges that people have? And how might somebody feel moving into aged care? When I've been thinking about this, it's interesting to put yourself in somebody else's shoes and think for a minute about how they might feel. So people might have been able to manage some small, simple tasks at home, and suddenly they're now in an environment where they're not able to do any or many tasks for themselves. They might feel a certain amount of depersonalization. They might be confused and disorientated, not understand what's happening to them. They become more of a resident rather than an individual. And so it can be a real and also you're suddenly living with many more people than you previously have been. Supposing you've been living on your own and now you're in an environment where there's other personalities to deal with, other people to get along with, and it can be really, really difficult. They might have left their spouse behind. So I think we really have to think about where people are coming from when they're moving into a changed environment like this. And then we have to think about how do we manage that change, and if people are having trouble and they are agitated or they are depressed, what are we doing about it? And as you all know, this year there was the Aged Care Royal Commission, and I had a read of the executive summary, and in that it talked about medication use in aged care, and I was surprised to see that 44% of the people that they surveyed were on some form of medication that can affect their cognitive function. So that's 44% of people on antipsychotics and benzodiazepines at the bottom, which is quite a large proportion. And so I want you just to have a think. I'm going to launch another poll now. I want you to have another think about what might be the harms caused by medications such as these. And just need to select 2. Going to give you all just a few more minutes to answer the questions. I think it's important that we think about the harms that we do with medications, because yes, there are instances when we need to use medications, but we always need to balance that against the risk. Okay. So I'm just going to show the results there. Interestingly, there weren't many respondents suggesting that stroke was a risk, where actually risperidone does have a very high stroke risk. But yes, all the other ones, as you can see, are harms caused by medications. So it is also a form of chemical restraint. And to a certain extent, you're not allowing that person to be able to be otherwise actively engaged in the environment in which they're living in. And so we do need to think about other ways in which we can get people to be engaged and reduce their agitation. So I'm going to talk a little bit now about the behaviours that we understand occur as a result of dementia and during the disease process. And I'm going to start by getting you to think about Maslow's hierarchy of needs. Now, this is something we're probably all familiar with from our studies. But Maslow's hierarchy of needs sets out that in order to be fully reassured and comfortable in our own existence, we need our base levels to be fulfilled. And that's food, water, warmth and rest, safety and security. And for most of us, we're able to achieve that for ourselves. But when we're in an environment where we no longer have the ability to do things for ourselves, then we're reliant on somebody else to take up those and fulfill those needs for us. So first of all, we need to think about, are any of the behaviours that people are experiencing as a result of them not having their basic needs fulfilled? And it could be just simply needing a drink or something like that. But moving on from that, it's not always that simple. And just because somebody has dementia and might not be able to communicate as well as somebody else, they still need that feeling of belongingness and love and emotion. And they also still need a feeling of fulfillment. And so we need to really extrapolate the unmet needs further than just the basics of food, warmth and rest, and think about what else does this person need in order to feel calm and relaxed. And if you think about this, some people who live in residential facilities will get washed and dressed by somebody who comes in to help them do that. But that might be the only touch they have all day. They don't have any relatives or carers coming in to see them, and perhaps they don't get time to be sat with staff busy doing other tasks. Then they might never have somebody sit and hold their hand. And so they might never get that feeling of belongingness and love. And it's really important that we think about that when dealing with patients and people living with dementia. So setting out the unmet needs, you can set them out in terms of whether it's a social unmet need. So is there an element of boredom or inactivity, or are they depressed? Whether there's a lack of engagement in what they're doing, so are they feeling lonely? And is there any environmental factors, as I said, feeling warmth, cold, drink, pain? So we're going to look at a case study now. And we're going to think about Joan. Joan, as you see here, has recently moved into a care home. And on her first visit, her daughter finds her crying out for someone to help her. Her daughter comforts her, takes her for a walk and talks softly to her, pointing out things of interest, and she calms down. And the staff reassure the daughter that it's early days and she'll readjust shortly. But on the next visit, the daughter finds her agitated, alone and shouting again. And now the staff member feels that she might be causing a bit of a problem, disturbing the other residents. What can we do in this circumstance? Are there any skills that you think you can offer? Any things that you could do to change Joan's environment or reassure the daughter that things are going to be okay? And I want you just to have a think about this. I'm going to set out now the sorts of skills and interventions that you might be able to offer using those areas that we talked about a minute ago in terms of social engagement and discomfort. So some of the things you might consider doing include using music as therapy, massage, which again goes back to that touch feeling, pets and dolls so people have a sense of belonging and fulfillment, one-to-one interaction as well as small group interaction. Some people prefer a one-to-one approach. In that example with Joan, her daughter took her for a walk and distracted her and engaged her in talking about things in the environment. Fresh air and walking is often a very good source of comfort. And it's also important that you look at somebody's sensory disadvantage. So if they can't see or hear properly, then their cognitive function is going to be affected. And then there are the other discomfort things. So I think probably everybody will be familiar with checking that people are not in pain. But there might be other things you can do, like if people are having trouble with bathing, for example, it might be the type of bathing that they're being exposed to. So changing the method or using music to make people feel more comfortable, or repositioning, or removing any restrictions, or if they're uncomfortable about who they're sitting next to, perhaps it's time to move them to a different spot in the dining room. So music features quite heavily in these various interventions, and I want to show you a video now about how music can really have a very powerful effect on patients who live with dementia.
I have one resident that barely opened her eyes. She didn't respond. As much as I tried, I knew her for 2 years. No matter what I tried, massage wouldn't work, nothing worked. But when we got introduced to the iPods and the family told me the things that she liked, it was amazing once we put the iPod on her. She started shaking her feet. She started moving her head. Her son was just amazed. Okay, can we stop? Because now I'm getting all I'm seeing her all over again.
Hi, Papa. Hi, Papa.
Huh?
How you doing?
I'm all right. Fine. Wait.
Who am I?
I don't know. Wait a minute. I don't know.
Okay, it's Jerry.
How long has he been in the nursing home? Approximately 10 years. He was having seizures, and my mother couldn't handle him at home. Of course, it affected me greatly because he was always, fun-loving, singing, every occasion he would come out with a song, no matter where he was. I remember as a child, he used to walk us down the street, me and my brother, and he would stop and do Singing in the Rain. He would have us jumping and swinging around poles. He was, he was good. He was always into music, always loved singing, dancing.
His name is Henry Dreyer.
Uh-huh.
And I'm looking more or less for religious music for him.
Okay.
Because he enjoys music and he always quoting the Bible. So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah?
Henry.
Yes, y'all.
I found your music. You want your music now?
What do you want me?
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression, his eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
The philosopher Kant once called music the quickening art, and Henry is being quickened, he's being brought to life.
Yeah?
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay? I'm going to give it back to you.
Uh-huh.
Okay.
the effect of this doesn't stop, because when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry,
Yeah,
do you like the iPod? Do you like the music you're hearing?
yes.
Tell me about your music.
Well, I don't have one, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound,
Did
beautiful.
Did you play music when you were did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, well, Cab Calloway was my number one band guy I liked.
What's your favorite Cab Calloway song?
Oh, I'll be home there for Christmas. Oh, you can count and plan on me with plenty of snow, mistletoe, present wrapped around your tree. Ow!
So in some sense, Henry is restored to himself. He has remembered who he is, and he's reacquired his identity for a while through the power of music.
What does music do to you?
It give me the feeling of love. No man. Figure right now the world need to come into music, singing. You got beautiful music in. Beautiful, oh, lovely. And I feel the band of love, the dream. The Lord came to me, made me holy. I'm a holy man. So he gave me this sound. I'll just say, I meet you. Let me see. Rosalie, won't you love me? Rosalie, won't you be sweet and kind?
With this beautiful new technology, you can have all the music which is significant for you in something as big as a matchbox or whatever. And I think this may be very, very important in helping to animate, organize, and bring a sense of identity back to people who are out of it. Otherwise, music will bring them back into it, into their own personhood, their own memories, their own autobiographies.
Okay, so hopefully you're all back in the room, and I think you'll agree that's a really insightful video to show you the power of music. And I do think it's a good idea to perhaps get some iPods or something like that, ask relatives the music, the kind of music that people are interested in, and really allow them to listen to music freely. I once watched a video from the Alzheimer's Society which explained that where we hold music in our brain is in the amygdala, which is really deep in the brain, and that's one of the oldest parts of the brain, if you like. So that's why people respond to music in that way. It's like the core of our being, like where your soul is, I suppose. And so that's why I really think it's important to think about music to help settle people and keep people calm, and it's something that most people enjoy. So we're going to look at a different case study now. We're going to look at James, who's a retired army general, and the nurse comes to get him showered, but James reacts angrily and he's resistant, and the nurse is worried that he's being uncooperative, perhaps a bit aggressive, and she's worried that maybe his dementia is advancing and this is affecting his behaviour. So I want to do another poll now, and I'd like you to have a think about ways in which you might approach this. If you could just select 3 of the following that you think might help to manage James's aggression and uncooperative behaviour. Okay, I'm going to give you another 10 seconds to final answers. Is it like the Millionaire Show, isn't it? Is that your final answer? Okay. All right. So, yes, perhaps it might be that James, if we ask a few more questions about his personal history and delve a bit deeper into the sort of person he was, it might be that he was somebody who liked to get up really very early and get washed and dressed first thing in the morning. Or it might be that he was somebody who'd like to take his time and get dressed later on, or maybe he had a shower before bed. So we could change the time that we get him dressed. It could be that it's the mode of which he's having his shower. So he doesn't like having his shower. He prefers to have a sponge or a flannel and wash in the sink or something. Or it could be that we use music again, which might be helpful to keep him calm and relaxed. And it would be music that he was interested in. So the key here is to find out more information about James and ask his family more about his personal history and really find out who he is as a person. And this quote just illustrates that again. So, as we said, a person with Alzheimer's disease is many more things than their diagnosis. And I really want to emphasize that to you today. Really think about the person. The more we know about people, the more we can understand why they react the certain ways that they do. Particularly with behaviours, it can be something about the person, that the carer that's interacting with them, that they might not like because of a past experience. It may be nothing that you've done. It may be nothing about the way that you're doing it. It may be simply that you're a female carer versus a male carer, or it may be your accent. But if you don't know enough about the person, you'll never really know why that person reacted the way they did. Or it might be that they're confused about whether it's day or night, or they might have a strange smell that's in the environment that's upsetting them. So we really do need to find out more about the person. Up until now, I've just been talking about how to manage people in residential aged care, but patients with dementia also often attend hospitals, and it's important for us to think about what might happen to somebody who does enter into the hospital environment. So if we just think about how often that might occur, it's thought that about a quarter of patients in hospital might have some form of dementia at any one time, and that it's not always recognised. So when they attend the emergency department or they get admitted, it might not be documented in their admission notes. And so then people don't know to manage that person in a slightly different way. It also might be something like, I remember when I was a house officer, patients used to come in and it was always written acute on chronic confusion. And confusion isn't really a diagnosis, but it never went further than that. People never really thought about what was underlying that. And it's important that when patients do come in with an infection or something like that, they may be experiencing delirium. And delirium is actually a red flag for dementia. There might well be a dementia underlying that delirium, because patients who go into a delirium often have a reduced cognitive reserve. And so although you can't assess and diagnose dementia in the presence of delirium, because obviously they're acutely confused and you need to wait until you've treated that infection, about 6 to 12 months later you need to reassess that person. And so if it's not documented anywhere in the notes that the person had a delirium or confusion, and it's not highlighted to the discharge summary, and it doesn't get back to the GP and the primary care team to reinvestigate that. And so this is how diagnoses of dementia get missed. You might be the first person to speak to family and find out that this person has been confused or their function has been declining. And it's all of our roles, if we are that first person, to flag it up to other medical professionals so that it does get investigated. The earlier that we make a diagnosis, the better we are able to support patients and help them to navigate what can be a very difficult diagnosis. We can enable them to access treatments which might help to slow the progression of the disease, and we can also help them to plan with their families where and how they want to be cared for and have a really open discussion about it. And so I think we all need to be thinking about making that diagnosis or talking about that diagnosis when we have the opportunity. Not only that, you might be seeing patients who come in who have a chest infection or have deteriorated and they're in a nursing home, but they get admitted because they're dehydrated or something, needing IV fluids. And we need to recognise that this might actually be the palliative stage. It might be the end stage of dementia, and we might be needing to talk about how to manage that and avoid unnecessary hospital admissions and have some really frank and upfront conversations with patients and their families about how to manage the palliative phases of dementia. So there are many impacts on patients in terms of what that admission might do. It can worsen their cognitive function. It can affect their physical function. We know that if people are in a hospital bed for just a week, they lose an enormous amount of muscle mass. The same sort of thing can happen to their brain, essentially. It can cause psychological and emotional distress, and it can cause even more difficulty in adjusting to what's going on around them. And there may be unfamiliar staff, which makes their agitation worse. So there are lots of impacts. But there are things that we as health professionals can do to help. We can take a really careful history, really go into that patient's details and think about who they are, what they were like, what they were able to do, what's changed, are there any concerns. Really find out a collateral history, find out from their caregiver what their concerns are. Are there any concerns about vulnerability, or are they struggling with their finances, or are there any safety issues in the home? That's where your social and home history comes in. You want to ask about their activities of daily living. Also, are they missing their medications? Is their blood pressure under control? Do they forget to take their tablets? Have they thought about advanced care directives? And all this information, a really, really good history, all written down, can be invaluable for that patient on their journey into hospital. But what if you are having a patient who is acutely agitated? What do you do? Well, here are some key strategies that you can implement. So always maintain eye contact. Talk in short, simple statements. Allow the person to respond. Smile. Be calm. And talk slowly. And always use non-verbal as well as verbal cues. It may just be a friendly, smiley face that helps to keep somebody from being really agitated. Also think about lighting and noise. There's all sorts of noise in a hospital, and that might be causing more agitation. So you want a quiet, not a particularly bright room, not too many contrasts of colour to help people feel relaxed. And if that's not working, then there's this handy cycle that you can look at. So look at any physiological causes for agitation. Try and treat those causes. So that's your unmet needs again, coming back to pain, discomfort, being cold or hot, needing a drink. And once you've implemented those things, has the agitation got any better? Have a look to see if other people in the environment are causing any worsening of the agitation, and remove those causes, and then reevaluate again. Then try some more positive comfort measures, so maybe moving the person or playing music or using other methods to keep them calm. And then try some analgesia, and you should be doing all of these before you use any form of tranquilizing medications. So we're coming to the end of the talk now, and we're going to have some time for questions. But there are a few things that I would suggest that you go away thinking about from here on in. What I really want you to do is spread the word about dementia. I want you to talk to your patients, talk to your friends and family, and really start to destigmatize this disease. The more we talk about it, the more it will become something that is just accepted, that we all have to face, and we can support people living with dementia. It was World Alzheimer's Day on Monday, and that's why this presentation was timed for this week. And so it's really imperative that we look to ways in which we can educate ourselves further. So you can become a dementia friend through Dementia Australia, or you could do the Tasmania MOOC course to further your studies. as I said, educating your friends and family, or doing one of the Dementia Training Australia courses. But really, I want to empower you to go back to your workplaces and reevaluate what you're doing, and if you're doing everything really well, or if there's any things you can do better, and try to avoid using medications where you can that aren't necessary. So, any questions? Silence. At the end, how to handle somebody who's falls with risk without restraints or medications. Yes, that can be a challenge, obviously. I think it's just about minimising their risk for falls. So if they, making sure that you have enough, the staff ratios are good, making sure that where the environment that they're living in, so if it's their own room, that there's, things that they're not going to hit themselves on, or making sure that if they can use walking aids, they are using walking aids. But we should be allowing people to still maintain some sense of independence and mobility where they can, because that can be good for patients as well. And there are details about how to get more information after this webinar. There's also an article that went along with it as well. The Tasmania course is called the MOOC. It's MOOC. I can probably send details out about that as well. It's free. How to handle a patient when she is forgetful. I guess you're meaning whether or not you should sort of reorientate somebody, or try to talk to them. I think it's just about, you don't want to agitate people. It can be really frightening if you can't remember what's going on. And so sometimes reminding people about what is happening all the time is not the right thing to do. So just keeping the conversation light, and not always picking on the fact that they're forgetting things, but just trying to encourage people and support them to do things where you can. I think the next question in the chat box is about unprovoked aggression, physical aggression in the aged care setting, when you can't get close to them. I think the thing about that is to, again, think about what's going on in the environment, what might be the triggers, and try to alleviate those triggers. I once was taught in a self-defense class as well, when somebody else is angry, or even a patient or a carer is angry, if you sit on the floor, it's very hard for that person to continue and maintain being angry at you. So if you reduce your physical height, then that person will feel much less overburdened by you in the room. So that's one way of minimising aggression. But you obviously don't want to be putting yourself at any risk, so you wouldn't want to be in a closed room doing that. But if you were to sit down on a seat perhaps outside the room, then that might help to calm them down. I think it is another question in the chat box is about whether or not it's appropriate to agree with patients if they think they're in a different setting, if that helps them to calm down. And I think that's entirely appropriate, because you want the person to feel calm and relaxed. So constantly reorientating them. So if they're asking to go home, or they think they want to be back at work or whatever, then that can agitate people further, thinking that they're being taken out of their environment. So I think if you're in the instance of trying to calm someone down, it's perfectly reasonable to talk to them in that way and help them calm down. Okay, so I think we've almost answered all of the questions. There's a question here about sundowning in the acute care setting. I think it's really hard in the acute care setting because obviously you haven't got the staff ratios in order to manage things, but it is about perhaps taking people for a short walk or keeping them, you know, on a one-to-one basis, or keeping them engaged in some other activity rather than using medications if you can. Or, as I said, you know, using changes in the environment, so music and things like that. But yes, when you haven't got the staff ratios, I completely understand it can be really difficult to do without using medications. And we're not saying you can't use them all the time, it's just try and use other methods before you rely on medications. And if you do have to use medications, make sure that they are always reviewed, because you don't want to be just continuing to use them when they're not necessary. There is lots of useful information for families and carers on the Dementia Australia website, and there's also something called DBMAS, which is if you're having trouble managing patients with difficult behaviours, and they have an emergency phone line that you can ring, and you can phone them up and ask for support, and they also have information for carers and families on there as well. So I think we're about out of time now. There's like the last minute. Are there any demographical areas of concern? I think the biggest thing that I've been thinking about with dementia recently is that probably rates are going up because a lot of the reasons behind people experiencing dementia can be related to cardiovascular risk. And so it tends to be in the areas where you have more problems with uncontrolled blood pressure, uncontrolled cholesterol. And so I don't think there are any particular areas of demographical concern, but those are the things that might put you at increased risk of things like vascular dementia. So making sure that we all take care of our bodies while we've got them is important. Okay. Well, thank you very much for everyone who turned up today, and thank you for listening to me.